morning, everyone. I'm Dr. Sripriya Srinivas. First of all, thanks to the organizing committee for giving me this opportunity. Imaging in liver disease is it's a broad topic. So my aim here is, since most of us are not radiologists, to show you lots of pictures and explain them as well a bit as we go. And the running theme, I think this time, is about evaluating the complex liver recipient. So with a view to that, I'll proceed. So this is a brief overview of my talk. So no talk is usually complete unless we have a brief overview of the cross-sectional segmental anatomy, about how we estimate hepatosis, steatosis and fibrosis on CT-MR. Some salient features in CLD portal hypertension and some points that we need to keep in mind while evaluating an adult or pediatric child for transplant. So this is a cross-section of the liver. This is a section above the porta. So like we have on the pictorial image, when we see the CT image, it is a good practice to always map out the hepatic veins, the right, middle and left, because then we can, so automatically the segmental segments form in our mind. So in a section above the porta, it's the segments 8 and 7 on the right, segments 4A and 2 on the left. This is a section below the porta. Usually the middle hepatic vein, even if you don't see, but you can see the gallbladder in the gallbladder fossa. And even if you can't see the left hepatic vein, you'd see the falciform ligament. So again, on the right, you'll have segments 5 and 6. And on the left, 4B and 3. So it's always nice to have the segmental anatomy and map it out when you are going through a liver scan. Every liver is different, and this kind of tells you, it helps us localize lesions. We can work out volume redistribution. So it's a good practice to go whenever we look at any CT image or CT or MR image of the liver. A brief thing of looking at hepatic steatosis. So liver attenuation index is on a plain CT. It is calculated as the difference between the average attenuation of liver and spleen. So if it's anything over 5, liver is usually more attenuating than spleen. So if it's over 5, that's a good sign. And what happens in fatty infiltration, the fat in the liver brings down its attenuation. So liver starts attenuating less than the spleen. That's when it starts going in the negative. Less than -5 is not good. The same thing can be done by MR fat estimation. So the algorithm in the software, it calculates, there are specific sequences that we run that will calculate the fat percentage. MR fat is actually much more sensitive than CT. And the grades that we know, we are all familiar with it. So we can grade the fat depending on the percentage that it shows. MR elastography, what we are doing is, we are sending shear waves into the liver, mechanical waves are sent, and depending upon the compliance of the liver, stiffness maps are generated. These are color-coded as well. So it is along the Vibgyor spectrum. So anything in the violet, indigo, blue range is okay. So once we start seeing areas of green, fibrosis has started to creep in. Green then goes on to areas of yellow and red as the fibrosis progresses. So the advantage of this is, on a T2 image in MR, you might actually have a completely homogeneous signal intensity. You won't really know that there is fibrosis going on. CT also won't be able to pick up. And it's at that point that when we superimpose the stiffness map, you can see that there are areas of fibrosis that have crept in, and this is only seen when you do the elastography. So this is that is the shear waves. This is which is then changed into stiffness map images, color-coded, and we can put a value on it and see what's the liver stiffness. So MR elastography is again very sensitive, reproducible, and a good estimation of fibrosis. This is a good going liver cirrhosis, so you can see the liver is now no longer violet and indigo, it's all yellow and red in keeping with fibrosis. Now this is how you work up a liver recipient. This is what we've been following at Global. I think it's probably the most important slide of my talk, because everything in terms of liver recipient workup is all to do with timing. So our first image, which is the arterial phase, should always be a late arterial phase. That's why I've circled these. So there should be some enhancement of the portal vein. Why? Because only then you can see any enhancing lesions in the liver against a relatively slowly enhancing liver parenchyma. Anything that's hypervascular will stand out. Any portal vein thrombus will stand out. So it's important to have this late arterial phase. Portal phase should show good opacification of the portal vein so that you're able to pick up any filling defects in the portal branches or the main portal vein. And always important to get a good hepatic phase so that you can see all the 3 hepatic veins and make sure that they are patent. A delayed phase can be done to look, in case there are lesions that are washing out, you won't see them as the scan is happening. So best is to do a plain late arterial portal hepatic and a delayed image and then look at the images at leisure. So this is for those of us who are especially not looking regularly at images. So this is some of the salient features of chronic liver disease. So this person has ascites. So this hypodense area on both sides is ascites. This is edematous bowel wall thickening, like a thumb printing it is doing. That is edematous haustral folds in the colon. You have splenomegaly there. And this is a cirrhotic liver. Now it is seen on a coronal section. So you can see a shrunken right lobe, a hypertrophied caudate in front of the IVC, irregular outlines to the liver, and we can make out the slight heterogeneous parenchymal enhancement that is seen in cirrhosis. I hope this is not the case when the surgical team walks into radiology to ask for a report. But there are specific things that the radiologist should be aware of and should mention. And these are the things that the clinician is looking for. So first thing is the portal vein. Patency of the portal vein are the branches patent. So we can see a filling defect here. That's a nice round filling defect. So we can be assured that this is a brand thrombus. We also need to see, is it just in the, what is the extent of the, so is it occupying part of the lumen, the entire lumen, and which portal branches is it involved? Is it the right and left main? Is it the main portal vein? Is it extending up to the splenoportal confluence? So here we can see in the main portal vein, you can see a partial filling defect which is reaching up to the superior mesenteric vein origin. It's important to look for this and mention it in the report because it helps the surgeon a lot in planning management while planning for transplant. So this is the Yerdel's grading. So it's the same thing what I said. So where there's a partial occlusion or is it a complete occlusion? Has it started extending into the SMV? How much is it extending into the SMV? And if there are any big collaterals that you can see, it's worth mentioning them. This is to differentiate a bland thrombus from I probably will put the next slide first. So this is the Avena criteria to look at a tumor thrombus. So it's very important that we know how a tumor thrombus will look like. So the main features in Avena that we will see in CT or MRR, that the vein gets expanded, the portal vein, with the soft tissue, and this can enhance and wash out. It can show new blood vessels. It may be adjacent to a site of HCC or a prior treatment site. So I'll go back to the previous slide now, as opposed to the bland thrombus that we saw in my previous slide. So here we can see, this is the late arterial phase and that's the hepatic venous phase. So you can see both the portal branches expanded by soft tissue. The soft tissue enhances and washes out. It is adjacent to a small tumor site here, which is the primary, and you can see the neovascularity. All these lesions of vessels are the blood vessels. So the tumor is basically fully growing into the portal vein. And quite often, I'm sure most of our surgeons and hepatologists will be aware, this can be actually the first presentation of the patient itself. So the patient comes to us with, suspected CLD, and you do the CT, and this is your picture. So it is possible that you are picking up an extensive HCC with invasion of the portal vein. So always when we look for tumor thrombus, the patient may be just being evaluated for pre-transplant and you pick up a tumor thrombus. So is it bland or is it malignant is an important criteria to differentiate. I think this I'll leave to Gayatri. This is just to show that if there is a portal vein thrombus, unlike the nice portal vein that we see there, that's a normal patent vein, you can have a leash of vessels sitting at the porta, that's a portal carcinoma. When there is portal vein thrombosis like that, there will be invariably large portosystemic collaterals. So here we can see large linorenal and perisplenic collaterals, probably draining through the left renal vein into the IVC. So important to look for collaterals and mention because again, they may need to be ligated before surgery. Otherwise, it will cause a steal phenomena. Yeah, cocoon abdomen encapsulating peritonitis. So this commonly can happen in CLD itself because of repeated episodes of SBP or repeated paracentesis, or sometimes because of associated infections. So look for cocoon. So normally in the ascites, the bowel loops should be free floating. So here we can see the peritoneum is thickened, enhancing, and the bowel loops are all clumped in the center of the abdomen. So this is a cocoon abdomen. It makes for a difficult transplant. So as a radiologist, we need to look for it, mention it, because it helps a lot. And once, again with everything, once we know what the mind knows, we will look for it. So look out for a cocoon abdomen in somebody who's being evaluated for liver transplant. And mostly if it's caused because of CLD, the same patient, this is while he was being evaluated post-transplant for looking at the liver, we found that the areas of the thickened peritoneum had started de-leaving, and nicely now the bowel loops are opening up and they are filling the abdominal cavity. So that's cocoon, abdominal cocoon. Budd-Chiari liver. Now, Budd-Chiari, the thing is, sometimes patients will come to us as idiopathic CLD. They would not have, you wouldn't know they have a Budd-Chiari, so always nice to look at hepatic veins. So first of all, do a good hepatic phase. So you should be confident that the hepatic phase should have picked up the hepatic veins, and if we can't trace the hepatic veins, it could be a case of Budd-Chiari. So what all do we look for in Budd-Chiari? So we can see this mottled enhancement. That's because of the differential drainage of the liver. The periphery is draining better, so that is more hyperattenuating. The central part is all congested. So you will see this mottled pattern of enhancement. You can, if there is any one hepatic vein that's draining, or if it finds one collateral, then you will see these intrahepatic comma-shaped collaterals that will be trying to drain through that pathway. And or if there are surface collaterals. So these are all nature's way of trying to get the blood out of the liver. So comma-shaped collaterals, surface collaterals, look for these. Most importantly, trace the hepatic veins, because if you can't trace them, then definitely this is a case of Budd-Chiari. This is another case just to show the caudate sparing. So this is obviously a very enlarged, engorged liver, a coronal section, and we can see the liver's weight is around 4.8, bigger than a baby. There is caudate sparing, so that's because the caudate veins usually drain directly into the IVC, so we can see that on this section. So I think this has been done to death yesterday with the Milan and the UCF criteria. So I'll just show, the main thing of this image was to just show that if you catch it in the late arterial phase, this HCC is nicely seen as an enhancing area that's washing out. This is the hepatic phase. So enhancing HCC, washing out in the hepatic phase. And look at this esophageal collaterals. You can see them. This is the hepatic phase, so you can see them. So quite a lot is obvious if you get the timing right. Now my next picture is so this yesterday Dr. Joy Varghese was saying, about when we have patients who have associated renal impairment, and he was talking about the renal impairment, but invariably that becomes a problem for us because, you can't give contrast for CT or MR. So what do we do? So quite often a plain MR with the T2 and diffusion images really helps in problem solving. So here we have, this is a T2 weighted image. So you can see the liver is dark, and it's a cirrhotic liver. This is it's hypointense on T2. Against this, there's a barely discernible, that's how HCCs will look. They'll be slightly hyperintense nodules. So, and when we go through the diffusion imaging, as the B value increases, so what we are looking for is restricted diffusion. So things like ascites, which are normally hyperintense, gallbladder fluid, the CSF, so they all get suppressed, and this cellular HCC will stand out in the diffusion images. I think I'll just proceed, just some more images are there to show. So this is again as how we can use MR equally to look for a pre-transplant evaluation. So here you can see that though we have not given contrast, this is just a plain MR. So you can see these slightly hyperintense, this is a shrunken right lobe. So this is all the right lobe, but there's a diffuse infiltrative HCC, this slight hyperintense signal. The soft tissue, again like the avenites, expanding, filling, so there's no signal void in the right portal vein. The better images are when you go to the high B value images, it's all showing diffusion restriction, which is extending up to the right main portal vein confluence. This is a few slides about pediatric transplant, just that when it's nice to have a look at these images. So the indications are usually biliary atresia, hepatoblastoma, or metabolic liver disease. So biliary atresia, this is a slide that shows, so you have the background features of liver with chronic parenchymal disease. These hypodense linear areas are the dilated peribiliary glands. So this is how it will look. Other things to look for in a biliary atresia is the portal vein hypoplasia. It's very important for the surgeon because he may need to do an interposition graft if the portal vein is hypoplastic. Other gut anomalies, malrotation, IVC anomalies, that will help, they may need to manage simultaneously. So this is a normal portal vein. So anything over 4 millimeters is considered good by the surgeon. So this vein is around 5.5 millimeters. So important to make sure the baby is sedated well so that there are no movement artifacts and you can clearly measure the portal vein. So that's a normal portal vein, whereas that is a hypoplastic portal vein, which is around less than 2 millimeters. So you can see how significantly dilated these bile lakes are. Next, some of the syndromic variants that we can see. So this is biliary atresia with polysplenia, so multiple enhancing areas on the left side. This is annular pancreas, so some enhancing pancreatic tissue is there, lateral to the duodenum. Other things to look for, gut malrotation, so make sure the DJ flexure is crossing, the SMA-SMV relationship is maintained. The last is, maybe I'm still again venturing into Gayatri's territory. This is the pre and post-hoc staging of hepatoblastoma. Again, our segmental anatomy comes here into play. So we need to localize. So we have the liver as 4 segments. So this is the COPL staging. So this is the right posterior, right anterior, left lateral, and left medial segments. So we try to localize where the lesion is before, so it's all quite self-explanatory. We just see how many segments are free of tumor. So this is stage 1, stage 2, stage 3, stage 4. Why is this important? Because I think post-chemotherapy, if it's stage 1 or 2, they plan for resection, and if not, they go for a transplant. So here, this is a huge tumor. I mean, I think the contrast enhancement is different, but it is the same child, baby. So there's a large tumor. It's involved the anterior, posterior, and up to the segment 4. And only a bit of segment, left lateral segment is free here. And this is post-chemotherapy. It has shrunken, but it still involves I think the right anterior and segment 4. So this still remains a pretext 3. It was pretext 3 before, pretext 3 later on also. But we can see the good response to chemotherapy. And usually they tether towards the veins. So that's a point to remember as well. So I think I've already overrun my time, so I'll stop at this. No, I'm done actually. So thank you. Let's take care of our liver and eat healthy.